Good afternoon, everybody. Just about to start the first of our afternoon sessions in this area. We like to try to keep on time, so we tend to be fairly tight with deadlines in terms of when we start and as we finish. If you have any questions during Professor Woodward's talk, if you can just put them through the app, and I've got an iPad down here, and those questions will come up, and I'll be able to relay them at the end of the presentation. So this session is sponsored by Nutricia, and pardon me, technology. Our speaker today is Professor Michael Woodward. Michael is the Head of Aged Care and the Head of the Memory Unit at Austin Health. He is a specialist in geriatric medicine with major interests in dementia and cognitive disorders, and is extensively involved in research trials on Alzheimer's disease and related disorders. Michael's also been a member of the board of Alzheimer's Australia and is the honorary medical advisor for Dementia Australia. So without any further delay, I'll introduce Professor Michael Woodward.
Thank you very much, Greg. And this is a really important issue, and I see the audience is growing, so I'm glad to see that. What I think you, as almost all community pharmacists, need to know is what MCI is, mild cognitive impairment, how it impacts upon you, and what impact you can make on your customers, your clients, your patients with mild cognitive impairment. And I think by the end of this talk, you'll have a fair bit of an idea about that. So we're going to describe mild cognitive impairment and the changes that occur in individuals with this condition. We're going to discuss the importance of early detection and the process of diagnosis. And we're going to outline the causes, the risk factors and prevention strategies, areas where you can make a real difference to your patients, your clients. So this is a very familiar story to me, and I'm sure it is to some of you. I've been worried about my memory or his memory for years. And I've brought it up, but I've been told, well, it's just normal ageing. What do you expect at your age? But your memory's better than mine. Nothing can be done about it, so diagnosis isn't important. Or you might actually detect that the person who comes back repeatedly to get lost scripts or forgotten where their Webster pack is or things like that might have a memory problem. So what is mild cognitive impairment? It's a transition state. It's a form frust, if you want to use that term. It's between normal cognition and dementia. To get to dementia, you've got to go through some early stages, and we call that mild cognitive impairment. But this is not normal ageing. So there is significant memory impairment, so it's not really mild. You could almost call it serious cognitive impairment. But it's mild because the person still has preserved function and independence. Most will progress to dementia over the next 5 to 10 years at a 3 to 5 times higher rate than those with normal cognition, and they usually progress to Alzheimer's disease causing dementia. But not all. Some actually revert to normal cognition, as you'll see on the next slide. If they've got a positive biomarker, and they'll be much more apparent and much more accessible in the near future, then they will convert if they live long enough. Some will take their mild cognitive impairment to the grave, but unfortunately, in many cases, they'll develop dementia due to Alzheimer's, and that'll push them into the grave, usually prematurely. So this is some trajectories. Normal cognition you'll see slowly declining because there are some changes, but not to the degree that we would call mild cognitive impairment. Once you reach the mild cognitive impairment range, you can sometimes revert back to normal cognition. You can become stable for many years, and that's actually the goal of what you might be able to do for your patients. And then you might convert to dementia over a 5 to 10 year period. Now, what people describe is changes in memory, so issues such as misplacing objects, using more notes and reminders than they usually do, repeating questions, having trouble keeping track of dates and appointments, leaving things on or open. There's many examples of these memory symptoms, and you'll see some of them in your clients. Just as a word of statistics, there's about 1 million people with mild cognitive impairment. Most of those are old people who would, on average, be going to your pharmacies 10 times a year. 10 million pharmacy visits divided by 5,500 pharmacies in Australia means that each one of your pharmacies is having about 5 people with mild cognitive impairment walk through your door every day. Okay, and if it's the same person every day, then they really do have mild cognitive impairment, but you know what I mean. There can be changes in language, having difficulty finding words. If you've ever seen the film Iris Murdoch, who had dementia, her first change was she forgot the word lexicon, and she actually was a language specialist. Changes in visuospatial function with driving or being slow to identify roadway hazards or late to apply the brakes or not staying in the driving lane are examples of this. And there's changes in other functions, executive and attention, easily distracted, difficulty preparing meals, but still basically can do it, just having more difficulty. If they can't do it at all, then they've reached the dementia stage. Now, as I said, we think that's probably about a million people have MCI. We know there's 480,000, nearly 500,000 now have dementia of all types, of which 60% is Alzheimer's disease, and I think it's at least 1 million that have MCI. There is a grey zone. As I said, you've got to have a loss of function to develop dementia, but what about if you can no longer pay a bill online? That's a very subtle change, but maybe you are moving towards the dementia stage if you lose that skill, having previously been a master at it. Sometimes we use the word mild Alzheimer's to include both mild cognitive impairment due to Alzheimer's disease and early dementia due to Alzheimer's disease. Lumping those two together is not a bad idea. Detecting MCI can confirm that the memory concerns are valid. The person might think they're going crazy, or they might be accused of having too much drink each night or something like that. The patient's usually aware of the changes, at least in the early stages. Knowing that they are at higher risk of developing dementia can also be a good prompt for them to look at how they're going to live the rest of their life, and that's where you can have a very important role. If we look at the numbers, you'll see the biggest circles in the East Asia and Southeast Asia areas. These are the total numbers of people with dementia, and as I said, everybody who develops dementia has gone through an MCI stage. So you'll see we are the centre, both now and in the future. That's those concentric rings of the dementia tsunami. It's estimated that by 2050 there'll be about 150 million people in the world with dementia, much higher than the number of people with Parkinson's disease, having strokes, etc. Now, there can be a number of underlying causes. This actually more describes the pathology that's causing the symptoms of mild cognitive impairment. And you can see the list there, but Alzheimer's disease, vascular disease, footballers who've had their head hit too many times, too much alcohol, other infections, other neurological conditions. Because MCI may be caused by different underlying conditions, from non-progressive, potentially reversible, such as depression, to those that are progressive to dementia, such as Alzheimer's disease, it's very important that they achieve an accurate diagnosis. But to do that, they've got to be detected. These are the people that you can make a big difference with. The diagnosis is, however, often delayed. Here's a study that I published a few years ago, 600 patients from 60 physicians. They started usually with their GP. They had quite a lot of memory problems even at their first consultation, and the mean time from first consultation to formal diagnosis, usually from a specialist, was about half a year, but longer if they were referred to another specialist. Sometimes you refer them to a neurologist who then refers them on to me as a geriatrician with an expertise in dementia. But unfortunately, about 50% of people with mild cognitive impairment are never given a formal diagnosis, 500,000 Australians by my estimate. But you may be aware of their memory issues. You pick up their blood pressure, or their GP does. Blood pressure doesn't cause, blood pressure itself isn't really a disease, it's a risk factor for disease. It's only when you get a stroke or a heart attack that you've got the disease. Well, you need to see mild cognitive impairment in the same way as elevated sugars or hypertension. It's a risk factor for dementia, and if detected and managed early, we can perhaps slow down that progression. It's very expensive. The cost to dementia is about $16 billion, mainly for care. So obviously most people with MCI aren't yet in care, but it's still a significant impact. People can't work as they used to. People need more help, more surveillance, etc. Common misconceptions. Thank God it's just MCI. I feared I had Alzheimer's. Well, as I think I've tried to show you, Alzheimer's causes MCI. But dementia is the clinical stage of Alzheimer's that most people are getting confused with here, and they're worried about that. I've had a CAT scan. It shows my brain is normal. It almost always is with MCI. Oh no, I'm going to end up like mum. Well, yes, if you live long enough, probably, but not if we do things to slow down the progression. If I do these things, such as exercising, crosswords, special diet, all the supplements, I'll never develop dementia. That is a misconception. You still might, but these can still make a difference. So what are the useful screening tests? What's happening with the brain? Can we modify this? What is your role as a pharmacist? And what may the future hold? The screening test, the one that doctors most commonly use is the MMSE. It's lousy for detecting mild cognitive impairment. It's too crude. It's good for dementia, but not for MCI. A better test is what's called the Montreal Cognitive Assessment, or the MoCA. It takes about 5 or 10 minutes. Now, I know many of you have now got consulting cubicles in your pharmacy for giving COVID vaccines and having a chat about their sugars or whatever. Well, you could use the same room to have a bit of a chat about their cognition and maybe offer them a cognitive screening test. We can use other tests if they've got a non-English speaking background or little education. We can use something called the RUDAS. There's another one for Aboriginal and Torres Strait Islanders called the KICA, the Kimberley Cognitive Assessment. But even just a few simple questions. Just checking. Do you remember what I told you last time about your medication? Shame about the huge storm last week. Shame the Broncos lost the match last night, or something like that. There's the sort of questions you can bring up in general conversation. Remember, you're monitoring people. You have a chat to people about their reflux, their arthritis, their medications in general. Well, you need to think about, in my opinion, having a chat to them about their cognition, particularly as the people walking through your door are progressively becoming older. What is actually going on? Well, basically, we've got misfolded proteins in most of these cognitive disorders. In the case of Alzheimer's, it's amyloid and tau, but there's other misfolded proteins in other conditions such as Lewy body disease, and there's a condition called late, which looks a bit like Alzheimer's, but it really only affects people over 85. This is the picture of the amyloid plaque, first described actually by Alzheimer about 115 years ago. I haven't got a picture of the tau tangles, but they are also well described. And what happens is that the amyloid precursor protein, a very long protein that's a natural production from chromosome 21, is inserted into the membrane, then gets clipped off by what are called gamma and beta secretases. And that makes the small fragment, the 42 amino acid fragment called amyloid beta. And that stacks up in plaques, they interact with tau, and you get the final process, which is loss of synapses. It's loss of synapses that gives you the symptoms of mild cognitive impairment. The brain, however, isn't without its own plasticity. It's constantly trying to replace and reproduce these synapses, but it runs out of the precursor nutrients that it needs when it's under amyloid attack. It's a terrible example and not very topical, but it's a bit like what's happening in Ukraine at the moment. They need weapons. Well, the brain needs precursors, and you can't get enough from your diet normally when your brain is under attack from this amyloid and tau process. So this is the amyloid shown on a PET scan. This is an amyloid PET scan. We've been doing them at my hospital for about 20 years. The bright yellow and reds are where amyloid is accumulating. That's not the same as another PET scan called the FDG PET, which was just made free under Medicare in November last year. It's still a useful scan. What you see here is the effect of amyloid, where you see hypometabolism, which is also shown up as increased green and yellow areas on the lines below the top line, which is just a reference line. This is a person actually with a frontal variant of Alzheimer's, which I've done a bit of work on myself. Now, you can also image tau. So at the top, you've got a tau tracer, which is also showing up as yellow and green, and then you've got the amyloid down below. Now, you'll see that there seems to be more amyloid than tau, and that's exactly what happens. So this is a person, 77, MMSE 29, shouldn't have been the MMSE, it should have been a MoCA that was done, a scale called the Clinical Dementia Rating Scale, which you won't need to do, and they have a significant loss of episodic memory, 1.9 standard deviations below expected. So this person has an undifferentiated cognitive disorder, but as a result of the scans showing they have both amyloid and tau, we now can diagnose mild cognitive impairment, which we also call prodromal Alzheimer's disease. And what happens is, over a period of about 30 to 40 years, you get a build-up of amyloid in the medial temporal lobe, the limbic area, and then the hippocampus, and that spreads progressively through the brain. But as amyloid spreads, secondarily, tau spreads. Amyloid is like the trigger, but tau is the bullet that does the most damage to synapses. Now, I've got a video coming up, and we're going to play that video, and if you look at the video when we're playing it, you'll see up the top the progressive increase in amyloid, and down the bottom you'll see secondarily the progressive increase in spread of tau. So let's play the video now, if we can, please. Drum roll, we've had a little bit of trouble with videos, but I'm assured we're okay. Oh, it's not on my screen, it is on yours. Ah, okay, sorry. So can we play that again? I'm sorry about that. Sorry about that. So you'll see at the top, increased spread of the green and yellow, that's amyloid. Down below, with a delay, you've now got tau. And this is a sequence over 40 years. This is what's happening as a person moves from normal cognition through mild cognitive impairment and now Alzheimer's disease. Thank you for that. We'll go back to the slides. Appreciate that. Right. Now, there are other ways of diagnosing it. I'm not suggesting everyone needs these zip-de-doo PET scans. You can look at the spinal fluid. We have a natural reluctance to give a spinal fluid specimen in Australia, but it's done very commonly in European countries such as Sweden and Germany, and there are very good analyses of amyloid and tau in the spinal fluid. MRI is sometimes helpful, mainly for excluding unexpected conditions, but it will also show the atrophy in the hippocampus, which is where the amyloid and tau begin. And very soon, this is a drum roll moment, you'll have blood-based biomarkers. Phospho-tau, excuse me, phospho-tau builds up in the blood even before symptoms. And soon, a blood test will be possible to confirm the clinical suspicion, not just for the general population, but for those where we have a clinical suspicion of a cognitive disorder. So you'll detect them in your pharmacy, you'll send them off to the GP will order the blood test, and if it's positive, we'll then send them on to a specialist for further assessment. That's the sequence. But while this is happening, you'll have a role, and I'll come to that in a moment. So what can be done? Well, we can't absolutely ensure that a person won't get mild cognitive impairment, but we can delay the progression of mild cognitive impairment to dementia. We need to do more, though. We need to destigmatise and make more dementia-friendly communities, including the community pharmacy. There are many ways that can become more friendly to those who have cognitive disorders. There are nutritional interventions, and I'll talk about those in just a moment. The cholinesterase inhibitors that I'm sure you're used to prescribing or dispensing for people with dementia due to Alzheimer's shouldn't actually be used for MCI. There's no evidence that they work. So drugs like donepezil, galantamine, rivastigmine and the various trade names, and memantine, which is really only useful for more advancing dementia. Now, you also need to be aware that drug classes can actually contribute to attentional and cognitive disorders, particularly those with a strong anticholinergic load, but also opiates, benzos, the Z drugs, even some with mildly anticholinergic effects like digoxin, antihistamines, tricyclic antidepressants, some skeletal muscle relaxants and anti-epileptic therapies can all have an impact on cognition. For instance, in the last one, topiramate is a terrible drug for cognition. Hormonal therapy for menopause has been shown to actually increase the risk for mild cognitive impairment or dementia. It doesn't mean it shouldn't be used. It has other benefits, but it certainly shouldn't be touted as a therapy to prevent dementia. There's no evidence of that at this stage. There might be evidence in the future. I'm doing a study on that, but it's a different hormonal combination to the one that's usually used for HRT. Hypotension related to the intensive treatment of hypertension and hypoglycemia, intensive treatment of diabetes, may also contribute to attentional and cognitive deficits. I can think of a few patients I've had in my room where I do my assessments of people with cognitive problems, and they were just away with the birds. And I thought, this isn't right, because their family says they were okay just a few months ago. I've tested their blood sugar and it's been 1.2 or something like that. So you have to have an awareness of that as well. Now, what about the risk factors for progression? Well, these include age, genes, we don't have much control over them, gender, family history, race and ethnicity. Really, none of those that we can have much impact on, of course. But then there are modifiable risk factors: education, lifestyle, medical conditions, social isolation and depression, and also cognitive inactivity. In fact, so here's some examples of lifestyle factors such as physical inactivity, tobacco use, unhealthy diets, harmful use of alcohol. Some medical conditions, mainly the ones that are bad for your heart, are also bad for your brain, but also depression. And this was put together in a Lancet Commission on the Prevention of Dementia, published in 2020. And you can see in this river of life, low education in early life, and in midlife, hearing loss, traumatic brain injury, hypertension, too much booze, obesity, and then in later life, smoking, depression, social isolation, physical inactivity, air pollution, and diabetes are all risk factors. And in combination, these lifetime risk factors attribute about 40% to your risk of developing dementia. In other words, you can reduce the risk of dementia in a population by as much as 40% by targeting these risk factors. 60% is those unmodifiable risk factors like family history and age, etc. Now, this was taken to a study called the FINGER study. It was initially done in Finland, thus the FIN, And they had a group of people who were potentially at risk of cognitive impairment because they had risk factors or they already had a borderline memory score, but it was still in the normal range. And this was a 2-year program with nutritional intervention, exercise, cognitive training, and intensive management and modification of metabolic and vascular risk factors. Then there was a control group that just got regular health advice. The intervention worked, people complied, there were no injuries, there were very few withdrawals, 2-year dropout of only 12%. And what they found, this is just the memory endpoint, what's called the neuropsychological test battery, they found a very significant difference in the intervention group compared to the placebo group at 24 months. So these sort of lifestyle interventions as a total are very helpful for people at high risk of cognitive impairment. And remember, I've said MCI is a high risk state for developing dementia. There's other programs. We have an Australian online dementia prevention initiative called Maintain Your Brain. It's the world's first internet program for dementia prevention. There's other programs. Dementia Australia, which I'll put up again on the last slide, have just started to develop a very important community program for the detection and the management of cognitive disorders in the mild stage, not just in the dementia stage. Now, I mentioned nutrition. The best diet for the brain and for the heart, of course, is the Mediterranean diet. And you might have heard of the MIND diet, which is essentially a modified Mediterranean diet. The way to think of the Mediterranean diet is if you grow it in your village, you eat it. You don't kill the family cow because you need the milk, so you don't have much red meat. You'll have lots of nuts, lots of vegetables, maybe fish that you've caught from the river or from the sea. You'll have pasta and nuts. You might have olive oil rather than other oils, and you don't have many sweets. That's the Mediterranean diet. Most of your protein comes from plants and fish. But what about other specific nutritional interventions? Well, this is where we get to what's called the Kennedy pathway. I've already said synapse and synapse loss are the problem here. We can target this through targeting the Kennedy pathway. And to do this, we need to front load the brain with uridine, with phospholipids and choline. And these in combination help to form new phospholipids and therefore more synapses, because synapses are just basically lipid membranes in touch with each other. There's a number of studies that have shown that there's a synergy between these nutrients. For instance, the 2 polyunsaturated fatty acids, UMP and DHA, as a single ingredient, do increase the amount of brain phospholipid, but in combination you get an additional effect. So you need to front load multiple components of this Kennedy biological pathway. And this led to an intervention called the Lipidi Diet Study. It was funded by the European Union, 36 months, randomised, double-blind, placebo-controlled. It investigated the effects of a specific multi-nutrient combination. The generic name was Fortisine Connect. The trade name that you might be familiar with is Suvinate. And it looked at cognition in 311 people with mild cognitive impairment, defined by a biomarker, so it was better described as prodromal Alzheimer's disease. And this is the results after 3 years. A significant lower rate of decline in an overall cognitive score called the NTB, but the memory score in the middle graph there declined very little in those on Suvinate compared to those on the control arm of the study, which is in blue there. And the other scale, which I briefly mentioned before, the Clinical Dementia Rating Scale, also declined less in those on Suvinate. These were highly statistically significant. They were published in the journal called Alzheimer's and Dementia a bit over a year ago. There were also changes in the rate of hippocampal atrophy. The hippocampus, as I said, is where all the action starts, and the hippocampus tends to shrink as we move from MCI to Alzheimer's, and that shrinkage was much less in those who were on Suvinate than those who were on control out at 3 years. So this is the first completed randomised control trial assessing a nutritional intervention for 36 months in mild cognitive impairment or prodromal Alzheimer's. Positive results on the CDR and other scales. And it's the first time a 3-year sustainable benefit has been reported in prodromal Alzheimer's disease for any intervention. So in the future, we're going to have other strings to our bow. There are disease-modifying therapies, including the biologicals. In fact, one monoclonal antibody has already been approved by the FDA for the treatment of early Alzheimer's disease. And these biologicals target the various toxic proteins that I mentioned earlier on. Now, they're probably going to be useful if they're used even earlier than MCI in those who are at risk of developing MCI, and they will be detected by the biomarkers that I've mentioned, including blood tests. But we need, as pharmacists, you need to assist in case finding so that people won't miss out on these therapies and the lifestyle interventions and the nutritional interventions that I've just been mentioning. So, I think I've come pretty close to time. I want to let you know again, mild cognitive impairment, usually due to Alzheimer's disease process, is common. As I said, about 5 people per day walk through your pharmacy doors with this diagnosis. But unfortunately, they haven't got the diagnosis in many cases, and that's where you can have a role. It needs to be diagnosed, and accurately so. It's a combination of factors. It's the community insisting on diagnosis, it's you as pharmacists and health professionals, general practitioners and specialists, all working in concert to achieve an accurate diagnosis. Much can be done to support and manage those with MCI, such as avoiding the medications I listed that worsen cognition and giving them the advice that they hopefully will take back to their GP. Preventative approaches such as exercise, lifestyle changes and nutritional interventions such as the use of Suvinade. Suvinade is indicated for mild cognitive impairment due to Alzheimer's disease. It's not indicated for those who are just worried about their memory. There's no evidence for that, but those studies will be done, I think, very soon. I've mentioned Dementia Australia. I'm one of the now 3 honorary medical advisors to Dementia Australia, and they have a particular interest now with another $100 million of government funding to help detect and support MCI. So be aware of that as a very useful resource. Thank you for listening, and I'll hand you back to our chairperson, who's down there.
Thank you, Professor. Just quickly, I've got a couple of. We've got time for a couple of questions from our audience. The first one is a low intelligence a risk factor for MCI?
Intelligence itself is not a risk factor, but less education is a risk factor. I don't think there's any study that's shown people with lower IQ are at risk, except those with Down syndrome, because they have an extra chromosome 21. And remember, I said that amyloid precursor protein comes from chromosome 21.
Thank you. And also, could you explain how hypotension can contribute to MCI?
So there's a lot of evidence that vascular risk factors contribute even to Alzheimer's disease as a whole, including the MCI stage. It's probably just through lack of oxygen and nutrient delivery to the brain. It might be more complex than that. Certainly repeated faints and unconsciousness are not good for the brain. One
final question. There are many new monoclonal antibody treatments about. Can they affect early onset dementia, particularly caused by neurological conditions like Parkinson's disease?
So the one, the one monoclonal antibody I referred to, aducanumab, has just received FDA approval in the States. It's in front of our TGA now. It's been shown to slow cognitive decline by about 30% in those with proven amyloid positive mild cognitive impairment and early dementia. These sorts of biologicals will be available in Australia. There's no biological that I'm aware of yet that targets the progression of Parkinson's, but there are studies looking at, again, monoclonal antibodies against the protein that's linked to Parkinson's, which is called alpha-synuclein. Different proteins, different neurological conditions, different biologicals, but they're all giving hope that we can actually slow down and prevent chronic neurological disease. There's not many drugs that help with most chronic neurological diseases. We've made some progress with multiple sclerosis, but that's a bit different. That's actually an inflammatory condition rather than a misfolded protein condition. So the answer to your question is yes.
That brings us to the finish of this first session in this area for this afternoon. So if you'd just join me in thanking Professor Michael Woodward.